Good afternoon, everyone. I'm Patty Nace, and I want to thank you for joining the Obesity Care Advocacy Network for today's briefing on obesity care, COVID-19, and communities of color. I'm the chair of the Obesity Action Coalition, which is a 75,000 member organization dedicated solely to representing the interests of people affected by obesity. I am also a member of the Academy of Sciences Roundtable on Obesity Solutions and the Global Obesity Patient Alliance and the World Obesity Federation's Policy and Prevention Committee. But my real qualification for today is the one I've worn on my sleeve since childhood. It's having had lifelong obesity. So I'm very happy that you're here to listen and learn more about obesity. The Obesity Care Advocacy Network, also known as OCAN, is a diverse group of organizations that have come together with the purpose of changing how we perceive and approach the problem of obesity in this nation. We advocate for a continuum of care, including evidence-based treatments and prevention options. As many of you know, this has been Obesity Care Week, which is led by the Obesity Action Coalition. Obesity Care Week has a global vision for a society that understands, respects, and accepts the complexities of obesity and values science and clinically based care. Obesity Care Week aims to change the way society cares about obesity and those who are affected by it by providing science and clinically based education on obesity and advocating for access to affordable and comprehensive care. I'm thrilled to be here with this distinguished panel of speakers. They have all dedicated their careers to helping people like me who are affected by obesity. So let me introduce them. Dr. Fatima Cody Stanford practices and teaches at Massachusetts General Hospital and Harvard Medical School. She was one of the first fellowship-trained obesity medicine physicians in the world. She has served as a health communications fellow at the Centers for Disease Control and Prevention and received notable awards from the American Medical Association and the American College of Physicians, and was honored as the Obesity Society's Clinician of the Year in 2020. Dr. Donna Ryan is Professor Emerita at Pennington Biomedical in Baton Rouge, Louisiana, and serves as past president of the World Obesity Federation. She is associate editor-in-chief of the journal Obesity, and she's authored more than 200 publications. Her research focuses on nutrition, obesity, and weight management. Dr. Bill Dietz is local to the Washington area. He's chair of the Sumner M. Redstone Global Center for Prevention and Wellness at the Millikan Institute School of Public Health and the director of the STOP, meaning Strategies to Overcome and Prevent, Obesity Alliance at the George Washington University. He's also a consultant on the Roundtable of Obesity Solutions at the Health and Medicine Division of the National Academy of Sciences. From 1997 to 2012, he was director of the CDC's Division of Nutrition, Physical Activity, and Obesity. And our fourth panelist, I'm happy to say, is Captain Heidi Blank. She has 21 years of CDC experience as a United States Public Health Service officer and has authored over 125 papers and reports in the areas of nutrition, physical activity, obesity, and environmental exposures. As branch chief of the Obesity Prevention and Control Branch in the CDC's Division of Nutrition, Physical Activity, and Obesity, Captain Blank leads public health strategies and programs that improve dietary quality across the lifespan and reduce chronic disease risk through childhood obesity prevention. Thank you all so much for being here today. And thank you for helping move the needle on the way we treat obesity. We have some special videos from two members of Congress, from Senator Bill Cassidy of Louisiana and Congressman Ron Kind of Wisconsin, on the importance of policy solutions in the effort to treat and reduce obesity rates. Let's take a look.
Hi, I'm Congressman Ron Kine, and I want to thank members of the Obesity Care Advocacy Network for inviting me to participate in your Obesity Care Week congressional briefing. The COVID-19 pandemic has shined a light on the need to reduce obesity in the United States. Obesity is one of the greatest risk factors for being hospitalized by COVID-19. That's why I'm proud to reintroduce the Treat and Reduce Obesity Act. This bipartisan legislation works to improve access to obesity care for seniors by expanding Medicare coverage for behavioral health counseling to treat obesity and allowing Medicare Part D to cover FDA-approved drugs for chronic weight management. I want to thank my colleagues, Dr. Ruiz and Representative Reed, for their continued leadership on this legislation, as well as our Senate colleagues, Senators Carper and Senator Cassidy, for their leadership on the Senate side. I look forward to building on this bipartisan support for the bill, as garnered in the past, to advance access to obesity care for Medicare beneficiaries. Thank you.
Hello, this is United States Senator and medical doctor Bill Cassidy. I emphasize the latter because I have seen obesity's effects on the physical and mental health of patients. The increased risk of COVID-19 complications further highlights the danger obesity can have upon someone's physical and mental health. To address this, we need a comprehensive approach of prevention and treatment. The approach must encompass the best standards of care with the best treatments available. Treating obesity must be a priority. That's why I support the Treat and Reduce Obesity Act. This bipartisan legislation allows Medicare to cover more therapies and medications needed to help patients overcome the challenge. Specifically, it increases access to care for patients by allowing additional types of qualified healthcare providers to offer treatment services. It also allows CMS to expand Medicare Part D coverage to include anti-obesity medications. We can pass these solutions. We can turn the tide on the obesity epidemic, and that will mean so much for so many. I appreciate your advocacy. I look forward to continuing to work on this issue.
Thank you, Senator Cassidy and Congressman Kine. We appreciate your support. Let's kick off our panel with an overview of the problem of obesity in the United States. Dr. Blank, let's start with you. I'm sorry, Captain Blank, let's start with you. The disease of obesity has been viewed as an epidemic in our country for years, yet obesity rates continue to climb. Can you talk to us about those trends?
Yes, thanks, Patty. So as folks know, when we think about global diseases, we think about the current pandemic of COVID-19. We may think about diabetes, but really we have a global obesity crisis. So in the United States, we've been monitoring through our surveillance systems and public health monitoring through height and weight as a measure of body mass index, or BMI. And we've continued to see over the past 20 years increases in obesity. So from the data from 2000 to 2018, we've seen an increase in the percentage of adults with obesity rise from 30% to 42%, and an increase in severe obesity from 5 to 9%. We look at our data from our states. For example, here in the slide, this is from our behavioral risk factor surveillance system. Looking at data we have overall and then by race ethnicity, unfortunately, we continue to see the increase in adults with obesity. The data shown here shows, unfortunately, also we have disparities by race ethnicity group. So, for example, in 2019, we have 6 states with obesity prevalence of 35% or more for non-Hispanic white adults, and that's shown in the far right panel. That goes to 15 states for Hispanic adults and 34 states for Black adults. So unfortunately, we're continuing to see very high levels of obesity.
Dr. Ryan, we know that obesity is a major risk factor for COVID-19, increased hospitalization, and unfortunately even death. A case of a chronic disease exacerbating the impacts of an infectious disease. Has this happened before, and what's the research telling us, and what do we do about it?
Yeah, I think we knew that obesity was associated with driving risk for many chronic diseases like diabetes, cardiovascular disease, even some types of cancer. And we knew that obesity increased risk for adverse outcomes of influenza. But this is nothing like the picture that we've seen with COVID-19. This disease now has over 500,000 deaths in our US population. So it's been a wake-up call. It's been a wake-up call that obesity is not a cosmetic problem. It's a medical problem, and it is putting patients at risk for this acute infection with the SARS-2 coronavirus, with COVID-19 disease.
Captain Blank, how do these disparities in obesity relate to what's currently happening with the pandemic?
Yeah, as Donna has said, we really have a convergence of risk. As we've looked at, what data we have related to racial and ethnic groups, for example, as I showed in the slide, similar to what we see in diabetes and heart disease, unfortunately, we have higher obesity rates in Black and Hispanic adults. These are also many of the same adults who are putting their lives on the line for us. Many of these folks are home healthcare aides, they're food service retail workers. There are many individuals who are really in the front lines of our essential workers in America. So they're unfortunately at an increased risk of COVID-19. And so we really are converging these two areas of folks who are at risk for obesity, they're at risk for COVID-19, and now we're continuing to see a severity of illness because of these risks.
Right. I mean, this is all making a lot of sense the way you all are laying this out for us. Dr. Stanford, we've talked how obesity has exacerbated COVID in communities of color. What lessons can we learn, not only about addressing obesity, but also to prepare for the next pandemic?
Yeah, I think first of all, we just have to recognize obesity for the disease that it is. It's taken us a long time to get here. It was only 2013 when the American Medical Association actually voted to acknowledge obesity as a chronic disease. And we've had a trickle effect in terms of making sure that we have the resources to care for this patient population that has this disease of obesity. Like we said, we have a disproportionate impact on communities of color. I think we need to think about the different reasons why that is. Structural racism, systemic racism is a huge point. We know that stress leads to deposition of adipose or fat tissue that is increased in communities of color. The Black Women's Health Study proved that back in 2014 when they looked at the impact of everyday racism and lifetime history of racism and obesity in Black women in the largest study done in that cohort, which is the cohort obviously that represents my demographic. But we have to think about all of the factors that play a role, and we have to think about access to care. And what I'm seeing universally throughout our country is access to care for patients that have the disease of obesity, especially in a respectful fashion, is really, far to come by. And so we need to do better for patients across the majority and minority, racial and ethnic minority populations here in the United States, Patty.
Yeah, I couldn't agree more. I mean, even in my position, I don't have coverage for obesity treatment except for bariatric surgery. But for instance, people would think I have good health insurance, but it specifically excludes coverage of FDA-approved anti-obesity medications. So that's one thing that needs to change, but you're absolutely right. We need to do a better job of thinking more broadly about structural racism and how that impacts all obesity, how pandemics run, and getting treatment to people who want it.
Absolutely, Patty. I think that you've hit the nail on the head. The fact is that we can have many different treatment modalities coming down the pipeline. I get all of these emails from people, oh, this new treatment, this is great. It means nothing if my patients don't get access to it. I care for a large percentage of patients that are from racial and ethnic minority populations, but I exclusively care for patients that have this disease of obesity. And often my treatment decisions are not being made based upon the standard of care, the highest level of what I can provide the patient. I'm looking, as I'm looking in their chart, to see what insurance they have and making my decision based upon their insurance status, not based upon the highest possible level of care I could provide in our country. And I think that's a dismal way for me to practice medicine for patients that need my help.
Do you find that to be true in many other areas of disease, in other disease states and the like?
No, I think this is, particularly challenging in obesity. I think that there's still quite a few people that have not been converted into this thought process of obesity as a disease. And, I've been told that I over pathologize obesity, but there is actual pathology. We have whole science. Let's look at the Donna Ryans of the world who've really spent their life at looking at the science behind this disease of obesity. So, as healthcare providers, as you, as an attorney, Patty, all of the public health officials that we have here, Dr. Deeds, Captain Blank, we're doing our work, but we need to make sure that we're getting this message to the broader community. Often we need to go into areas that may feel uncomfortable, spaces that may not be welcoming of this thought process of looking at obesity as a disease, and in teaching why we believe it to be so, because we have the data, we have the pathology, we know the hypothalamus regulates weight, but people, when you say that for the first time, they're like, what? It's not just what I did, it's something that I did to myself. No, and we need to remove the blame from the patient, but the blame from the patient often is coming from people like me, other healthcare providers that are making it uncomfortable to seek care within their setting.
Right.
Like I said, we have to do better. We recognize that obesity as a disease comes with a lot of weight bias, stigma, self-deprecation. Why should we be part of that problem? We need to be part of the solution.
Indeed, indeed. We've talked about treatment of obesity. We also know that prevention is important. Dr. Dietz, in the wake of COVID-19, what do you think are the most urgent priorities related to prevention?
Well, I think we have to sustain some of the federal policies that have been effective in controlling obesity in children. So both the WIC package, which changed in 2009 to provide a more varied and accessible series of changes, like a reduction in the volume of milk, the fat content of milk, a reduction in juice. These were changes in the dietary patterns in 2 to 4 year olds enrolled in WIC, which were associated with a decrease in the prevalence of childhood obesity in that age group. And we know that in the face of food insecurity, which we're seeing today as a result of the COVID-19 lockdown, that enrollment in WIC is a particularly important strategy, not only to address food insecurity, but also to sustain the gains that we made in the prevalence of obesity. And I think that the reversal that we saw in that first slide, the increase in the prevalence among 2 to 5 year olds, is a concern because it suggests that the WIC effect is not in action any longer. The second significant federal policy was the Healthy Hunger-Free Kids Act, which completely changed the food patterns available in the National School Lunch Program, so that 50% of all grains were whole grains. There was an increase in fruit and vegetable distribution. There was a decline in the calories in milk. And a recent study showed that was associated with a significant decrease of about 47% in low-income adolescents enrolled in the school lunch program. And with the lockdown, where the food distribution has changed and is including foods that don't require refrigeration in many places or don't require cooking, it's not clear whether those standards are being sustained. And that's unfortunate because, as I pointed out, we know that the prevalence of obesity is likely to increase, and we have data suggesting it is increasing in Medicaid patients and probably other children as well. Now, at the community level, we know that the Healthy Community Study, which was a study of 130 communities, showed a decrease in the prevalence of obesity among kids in communities where there were multiple significant policy initiatives related to nutrition and physical activity. Unfortunately, in those communities, there was not a decline in the prevalence of obesity among low-income communities of color that were oversampled. So about 30% of the communities had about 30% or more representation of minority groups. So the changes in the prevalence of obesity in response to those policies occurred in white children, not Black children, and not Hispanic children. And that suggests we need a different strategy of prevention directed at children that addresses more of these social determinants of health than simply the kind of policies that are so effective in white kids.
That's really interesting, an interesting distinction to draw. I think this discussion so far has really highlighted the complexities involved with controlling, preventing, and treating obesity. It's not, nothing is simple here. It's going to require systemic systems changes, basically, to really get a handle on this. Dr. Ryan, I'm curious to know from your perspective, what do you think the future of obesity treatment looks like? Are there any new developments or research that you're particularly excited about?
I am excited, Patty. I'm excited about two things that I'll tell you about. First, we're making progress in understanding the physiology and biology of food intake regulation, and we're transforming that into pharmacology. And we have some medications coming that are going to be outstanding and game changers in terms of our ability to help patients lose enough weight to get health benefits. So the FDA is reviewing a medication now. It would be available at the end of the summer, and it produces on average about 15% weight loss. That's enough weight loss to put diabetes in remission. It's enough weight loss to get people off of CPAP. If it's enough weight loss to start reversing the inflammation with NASH. These are all complications of obesity. So I am pumped about that. I'm also so excited about taking our knowledge and translating it to where it needs to be translated. So the PROPEL study was a study that looked at behavioral intervention in federally qualified health clinics in Louisiana. More than 2/3 of the patients in this study were African Americans, and we were successful in delivering an intensive behavior therapy for obesity that produced and sustained clinically significant weight loss over 2 years. And we did it. Yeah, we did it by embedding coaches in the clinics. We did it by producing culturally sensitive and health literacy appropriate materials for those participants. So both of those things they're exciting for me. All we need to do now is be able to implement them. And I haven't given up on childhood obesity. Everything Bill Dietz said, it encourages me that we know what we can do in childhood obesity. We know it can work, and we need the will to create healthier environments for all of our children. So I'm excited across the board, Patty.
I'm glad to hear that. You speak of needing the will to make these changes. Why do you think the will hasn't been there, not just in childhood obesity, but in covering treatment, those sorts of things?
I think people have been sort of in the old way of thinking. The old way of thinking is, oh, our patients just need to eat less and exercise more. And that is absolutely wrong. There's a lot of biology that underlies obesity. It has its own pathophysiology. It's not a matter of willpower. It's not a matter of telling patients they need to lose weight. It's a matter of giving them the resources, the skills training, the help with the biology to help them achieve and sustain weight loss. We know how to do this. We know how to do this in specialty practices like Dr. Stanford's, but we need to translate that out into the real world. And that's why I think the Treat and Reduce Obesity Act can help us get there.
Okay, let's get down to the legislation. So, Dr. Ryan, you heard Senator Cassidy and Congressman Kine speak about the Treat and Reduce Obesity Act, which we affectionately call TROA, and that it can be important, an important part of the solutions to the issues we've been talking about today. Can you explain what TROA would do for obesity care if it's passed?
Yeah, so TROA would affect Medicare. And Medicare really leads the way in terms of policy about how we're going to cover care for our diseases. So what TROA would do, it would throw open access to care for patients, both for good behavioral therapy and for medications. So currently, one thing that Dr. Stanford said was that, we only got obesity designated a disease by the AMA 20 years ago. It's been a short time frame. And I think Medicare policy currently has that old way of thinking that obesity can be solved with just eating less and exercising more. So I think what this would do is it would update Medicare to where we are in our understanding of the science. And it would allow for the reimbursement of anti-obesity medications where appropriate. And it would allow for appropriate intensive behavior therapy for obesity to be reimbursed in medical offices. It's likely that this step by Medicare would then be pushed down to states under Medicaid and to all of our third-party payers. Medicare really leads the way.
Right. And for those of us affected by obesity, the more coverage we can get, the better.
Yeah.
So just so you know that TROA has now been reintroduced in both the House and the Senate. The House bill number is HR 1577. The Senate bill number is Senate 596. And we'd encourage you to ask your members of Congress to sign on to support TROA now that it's been reintroduced. And anyone who wants to take action on this can visit the Obesity Care Advocacy Network.com for more information. So let's move to our audience questions. I want to thank all the panelists for your insights to this point. Let's get to some of the questions they've been asking. As those questions, let me ask Captain Blank one as we're waiting for the audience questions to come in. Are you seeing any hope in the data that your agency monitors about obesity? Any sense we're making a difference as a nation in reducing this disease? And perhaps how the pandemic has played into that too?
Yeah, so I think like Dr. Ryan, I'm hopeful. I'm seeing data related to increases in breastfeeding rates, which is the best early nutrition we have for kids. We're seeing more states embed nutrition and physical activity standards into their childcare system licensing, which provides a foundation for early healthy environments for our kids. We're seeing some slight increases in physical activity among adults. We're seeing some better policies around complete streets, which makes it easier for us to get around in our communities. We're seeing greater fruit and vegetable access in schools. So I think we've got some proxy measures here that show as a nation we can do it. We can put our will there, our shovels, we can build better communities. So I think although we're not seeing the obesity data itself changing, I think that as we make folks aware that this is a disease and that we have these environmental conditions in our communities, I'm hopeful that we can see a change in the future.
Thank you. We've had a request to repeat the bill numbers. I'm more than happy to do that. The House bill is HR 1577. That's 1577. And the Senate version is S596. S596. So those are the two bill numbers. Okay, back to other questions. And I think Dr. Stanford, you would be a good person to answer this one. Weight stigma was a theme of a different day during Obesity Care Week.
Mm-hmm.
Can you talk about specific strategies to limit weight stigma while dealing with the needs of people like me with obesity?
Absolutely. I think one of the first things I think we can do is think about the language that we use when we're talking about the disease of obesity. When we say the word obese, that is a label. Obesity is a disease. So we need to eliminate the word obese from our vernacular, our vocabulary, because we're talking about patients that have obesity. We don't say a depressed patient, we say a patient with depression. A diabetic patient, we say a patient with diabetes. And so we need to be respectful in the very same way when we're thinking about how we use our language. Another term that we use that is very stigmatizing, Patty, is morbid obesity, right? Like that is highly stigmatizing. We don't call it morbid COVID, yet we've lost over 510,000 individuals to COVID. Why don't we call it morbid COVID or morbid cancer? It's because we have such entrenched biases against patients that have obesity that we have to have language that corresponds with that. And so I think we should be mindful, thoughtful about the language that we use first. When we're thinking about our interactions with patients that have obesity, we need to be thinking about, are we treating patients with the same care and respect that we would any other patient, without judgment and without bias? And that often takes doing a deep dive to figure out what your biases are. So I encourage everyone, if you've not done it already, is to take the free weight implicit association test. It's on the Harvard IAT. So IAT stands for Implicit Association Test. You can go there and look for the weight IAT, and you can find, do you have significant biases in a very short period of time to persons that have obesity? And if you do, which most people do if you look at the results, then begin to work on your biases in terms of how you're interacting with individuals, whether or not you're making your space, if you're a physician, your space in terms of your office, how you train your staff to interact with patients that have obesity, encouraging and respectful. As someone who's a pediatrician and an internist, I can tell you that if a bad interaction occurs with a pediatric patient that has obesity with their doctor early in life, that sets up a really bad dynamic for seeking care throughout the life continuum. And it's often when I'm seeing some of my older patients that they're saying, well, back when I was, 5 or 6 years old, or when I was a teenager and I was interacting with my pediatrician, I had this really negative interaction, and that made me really withdraw from any type of care or therapy. So there's so many things we could go on. I can give an hour-long lecture on this topic, Patty, but I think that we need to be respectful. We need to be mindful, but first we need to identify what our biases are. And that would, start by taking the weight implicit association test to kind of see where you are, get a barometer, and then make some adjustments from there.
Do any of the other panelists have a comment on that question? Donna? I thought you raised your hand. Oh, okay. Well, let me comment just as a person with obesity. I face weight bias, stigma, and discrimination every day. And there's this assumption that weight is my fault and that it's a personal failing. And I'd like to dispel that notion. And anything we can do to dispel that, I think will help with removing some of the bias and stigma that people like me face. I encourage you to think differently about obesity, that it's not as simple as eating less and exercising more. If it were that simple, we would not have 42% of our population with obesity. We just wouldn't. But it's not that simple. And I hope one of the things we've conveyed today to you is it is much more complex than that. And that you really take that on board and think about the way you're thinking about obesity and how you're treating people with obesity. So yes, Dr. Dietz.
I think it's worth mentioning that people don't decide to develop obesity, and parents don't decide that their children should develop obesity. This is a consequence of multiple factors, environmental and biologic, as Patty indicated. And we have to remember that it's not a matter of personal responsibility. It's a matter of the kind of environment that acting on susceptibility genes that cause obesity.
Both very eloquent and both absolutely correct.
Thank you both. Thank you all. So we have a question about whether speakers can address the impact on our workforce and business community, productivity, retention, and recruitment. Bill, is that a question you feel is in your bailiwick?
Well, I can certainly start to answer that, and Heidi, I think, can chime in as well. This is the costs of obesity to an employer are very significant. And in fact, one of the things that I've been looking for and haven't been able to find is what the costs are of a severe COVID-19 infection in a person with obesity. Because I think that would make a very compelling argument for an industry to invest more strongly in prevention and treatment. The costs that have, there are two types of costs or several actually. The one is absenteeism, that we know that there's a higher rate of absenteeism among people with obesity from their jobs. And the second is something that's called presenteeism. And in the analyses that have been done, the cost of presenteeism are greater than the costs of obesity itself or the cost of absenteeism. And what we mean by presenteeism is that a worker is present, but not functioning at full capacity as a consequence of their obesity. And those, there are a number of companies that are developing or are quite sensitive to these issues. This was an initiative started in 2003 by the Business Group on Health, which has continued to be a leader in helping industries understand what the consequences of obesity are and how they affect their bottom line, because those costs to workers subtract from the profits that those companies make.
And maybe just to add, in addition to the business community, where we've tried to work over the years on really supporting work sites, whether that's with lactation rooms for new mothers, whether that's stress reduction through mindfulness and other kind of stress areas, food service guidelines to provide healthier foods through vending cafeterias. But we also work a lot with the Department of Defense. So for a lot of individuals, first generation and lifelong military families, it's really important to have the opportunity to serve in the armed forces. And unfortunately, we know that 1 in 4 of our youth today are either unable to take part in that as a job occupation because of their fitness or increased adiposity. So we're also limiting folks' opportunity to serve for the U.S.
Thank you, Dr. Ryan.
Yeah, I will refer everyone to a report by the OECD. This looked at the impact on the high and middle income countries of the obesity epidemic. And there are deleterious impacts on GDP, on future taxation. I mean, so looking at it from a national level is another interesting thing that this report does, the OECD report.
Thank you for that reference. We have another question from the audience that it's what resources are available to help healthcare providers better deliver obesity care for their patients? How can providers improve their skills? Perhaps Dr. Stanford and Dr. Ryan, you're probably in a good position. And Dr. Dietz, please, all feel free to chime in.
You know, I was hoping I'd get a chance to answer this one. I think there's a lot of things to do, and I'm going to spread the wealth with Dr. Ryan and Dr. Dietz. One of the things, you know, as was mentioned in my introduction, is after medical school, I came and did a 3-year fellowship in obesity medicine and nutrition here at Mass General and at Harvard. Part of that was that I wanted to be able to deliver the highest possible care to my patients across the age spectrum with overweight and obesity. Now, I don't think that, you know, we have enough bandwidth to get everyone through fellowship training. And so the American Board of Obesity Medicine has been certifying individuals that are going and taking courses taught by individuals like the people that you have on this wonderful panel today, which then allow us to build up our workforce. And we have now over 4,000 physicians that are board certified in obesity medicine through the American Board of Obesity Medicine. So there are efforts that are being made with regards to physicians, and we are seeing more efforts being made. We have some wonderful advanced practice providers that I see in this group today that are doing training in this field of obesity medicine. And so we just need to have better people trained to do this work. One of the things that has always been very hurtful to me as I think about what we learn and do not learn in the medical school environment is that our education surrounding obesity is minimal at best. I published a paper in the International Journal of Obesity just last year where I looked at across the world what type of education medical students, resident physicians, fellow physicians receive across their education spectrum regarding obesity. And there's an answer to that question, Patty, and we receive limited education at best.
Right.
How are we receiving such little education for the largest chronic disease of our lifetime? It's really distressing, and it shows that we really don't care because we don't put a priority on educating patients. If I ask people, if I'm speaking to physicians about really rare diseases, they're able to rattle off how to treat and how to diagnose. And then I ask them, how would you treat and diagnose obesity? And they kind of look at me with a blank stare. I think that speaks volumes to what we need to be doing in an educational standpoint for all, for example, the physician pathway. I'll let Doctors Donna and Ryan and Dr. Dietz speak about their perspectives.
Dr. Ryan?
I'm just going to blow Bill Dietz's horn. His organization, the Stop Obesity Alliance, has produced some outstanding materials to help primary care healthcare providers, not just MDs, DOs, NPs, PAs, get up to speed on obesity management. Number one is his Wait, Can't Wait project. Those are two plays on words. But he's also developed obesity competencies. He's also for education. He's also helped spearhead standards of care in obesity practice. What standards should we be practicing to? So I can't say enough about the wonderful work of the Stop Obesity Alliance. And Bill, you can add on to that.
Well, thank you, Donna. I think you've said a lot of what I was going to say. I think we have to recognize that one of the principal problems, which I think is a consequence of the stigma and bias associated with obesity, is many primary care providers don't know how to open the conversation about obesity. And once that conversation is open, they don't know what to do. They probably long-term are not going to be capable of treating obesity. On the other hand, diagnosing obesity, engaging the patient in care through shared decision-making, which is an essential element of care, and following up that care is something that they can do. And I think that we emphasize that in the Wait, Can't Wait guide as a strategy, and outline a very specific series of steps that the provider can walk through with the patient. But as has been said earlier, language is important. Listening is terribly important because as both Dr. Sanford and Dr. Ryan indicated, too often the prescription is eat better, exercise more, rather than sharing the decision with patients, because it's really up to the patient to decide what they're going to do and how to assess the outcome of what they're going to do. So part of that decision-making process is establishing metrics for what the patient is trying to achieve.
Thank you all for those answers. If you want to learn more from the patient perspective, you can go to the Obesity Action Coalition's website, and you will learn a lot more about people who actually live and are affected by obesity. Lots of materials there for you as well. And I think something Dr. Stanford said about education about obesity, that definitely needs to change in all professional medical schools. I've had the pleasure of working with both the medical school and the physician assistant school now at George Washington University. And the response has been pretty overwhelming, educating these young professionals, most of them are pretty young at least, about what it's like to live with obesity and the stigma and bias that's involved, and how to engage in shared decision-making too. It really, I think it can have a big impact to get medical professionals early on in their career track educated about this. So I want to thank you all for your time. Do any of the panelists have any closing remarks you'd like to make?
Yes, first of all, I just want to thank you for convening such a wonderful group. It's wonderful to be here amongst friends, amongst experts who are really dedicated to, really tackling this very pervasive chronic disease. I think that we need to be mindful that we need more allies. We need more people on the ground. We need more soldiers in this fight. And I think that hopefully those that are listening, if you're thinking about converting into being a strong advocate for patients that have obesity, that we want to bring you over. We want you to be part of this work. This is not just the work of those that you're seeing here on the panel. This is the work of everyone. So I want to thank you so much for having me. And I just want to leave that as kind of one of my closing thoughts.
Dr. Dietz?
So I think that as was mentioned earlier, reimbursement for obesity care is a significant barrier, and TROA will make a difference. We know that when physicians raise the problem of obesity with patients, patients are much more likely to act on it and are actually able to lose weight. But the incentive for doing so requires reimbursement, just like any other medical service. So please support TROA.
Right, thank you. All right, I think that's all the time we have for today. I want to thank the panelists first for just your wonderful contributions. And as a person affected by obesity, I want to thank you for dedicating your careers to this work. It's humbling and it's important. Just as a closing note for those of you who may be with congressional staffs that are listening in, here's something to think about. 42% of your constituents, essentially, are affected by obesity. That's a big part of your constituency. With TROA, you have the opportunity to move the needle for them, to make it easier to access science-based obesity treatments. We know that the lack of those treatments have caused additional COVID deaths. Lack of access to those treatments have resulted in death. But you have the power to change that. And we encourage all of you to support the Treat and Reduce Obesity Act. Please feel free to continue the conversation with us now during Obesity Care Week and in the future by following OCAN on Twitter at Obesity Advocacy and searching for the Obesity Care Advocacy Network on LinkedIn. Thank you very much. I appreciate it. Appreciate your participation.